Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Burt to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Burt Kushner.
Welcome to the One World, One Vision comprehensive course on strabismus and today's lecture on rectus muscle surgery. If you're new to the series, I'm glad you're here. And if you are a repeat viewer, I'm happy to welcome you back. Today, I'm very pleased to introduce our speaker, Dr. Tjeerd de Faber from Rotterdam. Dr. de Faber is a pediatric ophthalmologist at the Rotterdam Eye Hospital, and interestingly, he's a consultant to the Rotterdam Zoo Blijdorp. I give you Dr. de Faber.
Hello, today I would like to speak about rectus muscle surgery, a comprehensive course on strabismus delivered to you by One World, One Vision. Rectus muscle surgery, we will speak about the types of incision, pros and cons of the incision types. Recession is a weakening of a muscle. Resection is a tightening of a muscle. We will talk a bit about plication, posterior fixation, pulley stabilization, and intraoperative issues. Furthermore, I would like to talk about force duction test, the spring back test, and whether or not position under anesthesia has some influence on your decision. And of course, complications and how to avoid them. There are several types of incision. The limbal incision, you will have better exposure of the extraocular muscle and safer in brittle conjunctiva, but the wound close to the cornea. Swan incision is an incision over the muscle insertion, which gives you good exposure but gives conjunctival scars. The fornix incision, the wound is covered by eyelids but less exposure. MIS is the minimal incisional strabismus surgery. Minimal incisions make less scarring of the conjunctiva, but exposure and overview of the extraocular muscle is limited. Let me first show you the limbal incision. With Westcott scissors and a surgical forceps, you open the limbus. The mis-incision, which is propagated by Daniel Maujean from Switzerland, only uses two small incisions to get exposure to the extraocular muscle. Recession of the rectus muscle. You use this to weaken the muscle by placing the muscle posterior to the anatomical incision. And with the same innervation, the resulting muscle contraction will result in a smaller rotation of the globe in the field of action of this muscle. Let me show you how this procedure goes. After opening the conjunctiva, which you already saw, you hook the muscle with 2 muscle hooks. Then you use a Vicryl 6/0 suture to suture one side of the muscle. And then a second suture with a spatulated needle is used to have a safe 2 ends of the muscle sutured. With Westcott scissors, you trim the extraocular muscle from the anatomical insertion. And then with calipers, you measure how many millimeters you would like to recess this muscle. The first suture in the sclera you can see here at the intended distance of 5 millimeters. And then the second suture in the sclera. Then you tie the sutures appropriately so that the sutures will not spontaneously untie. And then you close the conjunctiva with a Vicryl 7/0 sutures. These are the Vicryl 6/0 sutures which I use for the extraocular muscle. And this is this Vicryl 7/0 for the conjunctiva, which I use in the Rotterdam Eye Hospital. At the end of the surgery, check wound closure, trim off excess tenons and conjunctiva when it covers the cornea. I use subconjunctiva long-acting topical anesthetics, which can be helpful for the first hours after surgery to relieve pain, especially if you check the patients a few hours after the surgery because they can open their eyes without any pain. And check the springback test. But even before starting surgery, something which is very important, you do the timeout procedure. You ask yourself the following questions. Is this the right patient? And recheck versions and the cover test. Is the patient fit for anesthesia and surgery? Which eye or eyes are we going to operate on? Which muscles? What procedure and how many millimeters? Have a surgical plan visible on the wall from your surgery site, and have a plan B in case forced suction or the position under anesthesia is unexpected. Von Noorden in 1985 shows here the pictures of posterior fixation with recession. So you first do the recession, and finally you tie the posterior fixation sutures, you tie them. As a matter of fact, Gunter always first placed, after losing the extraocular muscle, place the posterior fixation sutures, and then fix them at the sclera, and then tie down the absorbable sutures 6/0 to place the muscle at the intended recession site when possible. You can also use posterior fixation without recession. Then you simply hook the muscle, go as far back as possible. I will show you the numbers he prescribed. Posterior fixation suture I use for this posterior fixation non-absorbable Merceline 5/0 sutures. The recommended distances of the posterior fixation, and these are the distances behind the anatomical insertion. For the medial rectus, that's between 12 and 15 millimeters. The lateral rectus between 13 and 16 millimeters. and the superior rectus between 11 and 16 millimeters. The inferior rectus muscle between 11 and 12 millimeters. Technically, I try to go as posterior as possible, and then somehow you're in between these numbers which Dr. von Noorden recommended. Now, a resection of a rectus muscle. A resection is used to tighten the muscle in order to get more effect of the innervation by the motor nerve in the direction of the action of that muscle. The amount of resection depends on the preoperative measurements, and force reduction test is important to rule out a possible contracture of the antagonist. Resections will have less effect when the muscle has any degree of paresis. And of course, in resections, you will remove viable muscle tissue. After opening the conjunctiva, which I already showed in previous slides, you measure how much resection is needed in the extraocular muscle. Placing the first suture at the right distance. Make sure that you're a little bit away from where you need to cut the muscle. Otherwise, you might cut your sutures when they are too close to that intended resection site. After the second suture at the same distance, we then cut the muscle, not at the insertion, but at the intended millimeter distance from the insertion where you would like to have the muscle cut away. So you measure the amount of muscle which you cut away, and then cutting out the intended strip of muscle, and then attach the muscle at the old anatomical insertion, and the net resection is the amount of muscle which you have cut away. And then close the conjunctiva with the absorbable 7/0 vicryl sutures at the limbus. At the end of the resection, check if the muscle end is straight at the insertion. When there is a central sagging, place a third suture in the middle of the insertion and advance the central sagged muscle. Because if you don't do that, you might get less effect from your resection than intended. Do a spring-back test in order to rule out a possible overcorrection with a too tight muscle. Sometimes you combine a recession and a resection in the same eye, and when you combine that, first do the weakening procedure before the tightening procedure. So first the recession and then the resection in order to have less manipulation of the resected muscle, which has more risk of snapping loose from the globe because there is more tightness in that resected muscle. And if you do that muscle as a second procedure, then you have less risk of losing that muscle. Tips for squirrel suturing. Use side-cutting spatulated needles. The squirrel bite should not be too shallow to risk a muscle detachment. And the squirrel bite must not be too deep, risking perforation and possible retinal detachment. Keep your tip of the needle up like a bow of a sailboat going through the waves. Don't make your needle a submarine. When the needle is halfway through the squirrel tunnel, it's round and then it's not sharp anymore, and that can help you by manipulating the needle if the operating site is very tight. So then it's safe after the muscle is after the needle is halfway. Then you don't have to pull it out straight, but you can do it also sideways. Some more tips for scroll sutures. The sclera is thinnest just behind the insertion, so outside the thinner wedge where the muscle used to slide, it is thicker and a good anchor in which you can place your sutures. Go from thin to thick. At the original anatomical insertion, the sclera is thickest. Suturing is safer in terms of how deep you can go with your needle. The suture should hold 40 grams of muscle force. By the way, a normal globe weighs 7.5 grams. Here you see an illustration where you go from thin to thick with scroll sutures. That means that sometimes you have to use your forehand or your backhand if you're a right-handed or a left-handed surgeon. But go from thin to thick, and that helps you to prevent scleral perforation. Scleral perforation occur intraoperatively during a reattachment of a rectus muscle, and you can prevent an excessively deep scleral entry by keeping the needle parallel to the sclera. The sclera needle track should allow visualization of the needle through the entire length. So always have visibility of the needle during this scleral tunnel. In case this happens, dilate the pupil and study the retina. No treatment should be carried out unless retinal detachment is present or impeding. So don't do a preventive coagulation or laser treatment because it's probably not necessary. And make good notes in the electronic patient file so that you check and recheck that perforation site in the weeks after the surgery. Plication of a rectus muscle. Plication of rectus muscles tighten a muscle, and that's an alternative for resection of a muscle without losing muscle tissue. The advantage is quicker than a resection, no risk of a lost muscle, and no muscle tissue lost. And it also can be used in a vessel-sparing manner. The disadvantage, however, is in large plication, a bump can last for several weeks to months after surgery at the surgical site. Repair of damaged rectus muscles. What was the story of the accident? Any damage to the eye? Sharp or blunt trauma? Do a motility exam, and is imaging needed? Lost, ruptured or cut muscle? Slip muscle, or is there a flap tear? My motto in these cases is don't despair, but repair. Try to retrieve the muscle. If the muscle is torn, suture end to end and use Botox in the antagonist. This is important in order not to get a contracture of the antagonist, and that may also, the Botox will be useful in weakening the antagonist. So in the meantime, the torn muscle can grow together. If the extraocular muscle is lost, use partial transposition of neighboring muscles. It's I call this help of the neighbors. Repair a flap tear as described by Irene Ludwig. Force duction test, abbreviated FDT. This force duction test gives you information about how tight or floppy are muscles. Are there any restrictions and in which directions? A tight muscle will respond more to a certain amount of recession than a normal muscle. Check force duction test also after taking off a tight muscle. When the force duction test is still not normal, the tight muscle is not the only cause of restriction, and that can help you in further clinical and surgical decision. And here you see a quick normal force duction test. The following force duction test is normal in the left eye, but abnormal in the right eye. You see here the normal elevation, but in the right eye you see there is a restriction to abduction and to elevation. Springback test. The springback test can be used to get an impression about the tightness of a muscle before and after surgery. When a globe will spring back into a position which is too far from the primary position or too far into the position of the just resected rectus muscle, which is a sign of overcorrection, the muscle needs to be adjusted in the same session, or adjustable sutures which can correct the eye position after the surgery in the recovery room or in the clinic, depending on your working situation. Position of the eyes under general anesthesia. Some authors advocate that the position of the eye under general anesthesia will help to determine a better dose-response outcome in correcting strabismus. I personally will notice the position of the eyes under general anesthesia, but it will not alter my surgical plan, other than that I recheck my operative plan if the patient shows a paradoxical eye position. In my hands, force duction test has more often influence in altering my surgical plan than the position under general anesthesia. Adjustable sutures. I've done several adjustable suture techniques, but do not feel comfortable with these techniques. I rarely needed to adjust. In case of an unwanted over or undercorrection, I will adjust in another surgery, and the patient is informed about this possible touch-up surgery before the patient is scheduled for the first strabismus surgery. So I know that several other colleagues will use adjustable sutures. I am not really a fan of it, but it can be helpful, and I think Dr. Kushner will talk about this a little bit after my presentation. Postoperative infections. Conjunctivitis, either infectious or allergic. Granulomas due to foreign body, for instance the sutures. Epithelial inclusion cyst, subconjunctival abscess, orbital cellulitis, and endophthalmitis. And I will go this list down in the next slides. Of course, what is very important is prevention of infections. So work under sterile conditions. Look for snot coming from the nose and the lacrimal puncta, especially in young children. Disinfection of skin and fornices with betadine iodine, and wait 3 minutes for the effect of the disinfection. Drape carefully to prevent exposure of non-infected skin and eyelashes. Some surgeons dip the sutures in the iodine before use. Prevention of infection during surgery. Work clean. Treat blepharitis and other infections long before surgery. Try to avoid eyelids, skin, and eyelashes, and do not bury eyelashes under the conjunctiva. Close wounds tied with absorbable sutures or tissue glue. And avoid prolapse of tenons, because this can work as a wick for an infection to go under the conjunctiva. And here you see an example of prolapse of a Tenon's capsule. Tenon's capsule may prolapse through conjunctival wounds as a result of edema during the postoperative period. You can prevent this by conjunctival closure to be meticulous with accurate apposition of the tissue and push tenons back, or if it still wants to come back, trim it off. In most cases, the prolapsed tenon capsule will retract or disappear spontaneously without surgical intervention. Here you see an infected tenon prolapse, something which can happen anyway. This was in a fornix incision, so an infected tenon prolapse. And this you can use, this you can treat with antibiotics, and if it doesn't retreat, you have to trim it off and do a reclosure. Dellen. Corneal dellen are small areas of thinning associated with adjacent conjunctival swelling, as you can see indicated by the arrow. Prevention, you have to smooth closure of the conjunctiva, and you see this less in fornix incision. The treatment of dellen are occlusion of the eye for 1 or 2 days with an eye pad and ointment, lubricating drop, or an excision of the offending conjunctiva. Chronic suture granuloma. Here you see in this slide an example of a localized hyperemic mass over the muscle insertion, and it represents a non-allergic foreign body reaction to the suture material. You can prevent that by using synthetic absorbable sutures, which we actually already do. But you can also treat it with topical corticosteroid drops. And if worse comes to worse, you can, of course, do an excision of the granuloma. And here you see an example of a pyogenic granuloma, which was treated with antibiotics. Sometimes you have to be very cautious, especially in patients who have Wegener disease. And this is a wound of after strabismus surgery in a patient who had Wegener disease. In this girl, you see a subconjunctival abscess of the left superior rectus muscle. You see the ptosis. You see also the limitation of elevation of the left eye. And in the CT scan, you see that there is an abscess in the orbit at the place where she had strabismus surgery of the superior rectus muscle. And this is another view on the CT scan, and this is the view of the abscess in the left eye in the area of the superior rectus muscle. And we made an opening to evacuate the pus, and this is what happened. A huge amount of pus came out of this abscess, and the patient recovered quickly also after systemic antibiotics and local antibiotics. And it was a Staph aureus bacteria which caused this infection and the abscess. Orbital cellulitis is very rare after strabismus surgery, but it can happen. And the clinical signs are eyelid edema, pain, conjunctival redness, proptosis, decrease of motility, fever, and leukocytosis. Perform imaging to differentiate between preseptal or orbital cellulitis. And the treatment should be hospitalization with intravenous antibiotics. And this is an example of preseptal cellulitis. And in this child, you see that the snot is coming from a nose. And this actually caused preseptal cellulitis. This was not around strabismus surgery, but just as an example that if you see a case like this, treat the child for the cellulitis and don't do strabismus surgery, because this is a really red warning sign to postpone strabismus surgery. And this is a case of orbital cellulitis. the child needed to be treated with intravenous antibiotics in the hospital. Endophthalmitis. This is a potentially blinding complication and generally associated with inadvertent scleral perforation, but there are series who show that in 50% of the endophthalmitis after strabismus surgery, no perforation of the sclera was found. So even without perforating the sclera and going into the retina and vitreous cavity, you can get an endophthalmitis. While the incidence of scleral perforation is in the level of 10% in the literature, the incidence of endophthalmitis after strabismus surgery is very low. We think it's about 1 in 30,000 cases. And here you see an endophthalmitis 5 days after left lateral rectus recession and also right lateral rectus recession, but only endophthalmitis occurred in the left eye. And you see this hypopion in the left eye, a closer up slit lamp photograph on the lower left slide, and you see that there is a real endophthalmitis because also the ultrasound of the vitreous cavity shows signs of infection. And this is the same eye just before our vitreoretinal surgeons did a vitrectomy. And interestingly, no perforation of the sclera was found, not from the outside, but also not from the inside. The retinal surgeon really inspected the peripheral retina at the suture side of the lateral rectus recession and could not find a perforation. Inclusion cysts can happen as a result of your surgery, but you will only find this if you do resurgeries, and they need to be removed because they can limit motility. Here another epithelial inclusion cyst in the left eye of a young boy who had a medial rectus recession of the left eye, and this is what we found about half a year later when he complained about this tumor in his left eye in the superior nasal quadrant, and this was in toto removed. Sometimes patients can come to your clinic and say, well, what is this line in my operated eye? And this is a visible line of the previous muscle insertion. When a muscle is recessed from the former side of the original muscle insertion, it becomes visible through the conjunctiva. And there is no treatment for this minor complication, and reassurance and explanation are all that are required. You just have to explain it to the patient that this is just altering her or his normal anatomy in order to get straight eyes. Lid fissure anomalies. Lid displacement after vertical rectus surgery occur in the same direction as the shift of the insertion of the vertical muscle. So if you do recession of superior or inferior rectus muscles, the lid fissure will widen. But also, if you do a medial rectus or lateral rectus recession, may induce the widening of palpable fissures. Resections, however, may produce a narrowing of the palpable fissures, and sometimes you can calculate that in if you already see asymmetrical lid fissure, that you can use your resection or recession in order to make it more symmetrical. Anterior segment ischemia occurs when the anterior ciliary arteries are interrupting during the course of strabismus surgery. And the clinical manifestation of anterior segment ischemia are most clinically detectable by a mild self-limited iritis. More severe anterior segment ischemias result in significant iritis with pupillary abnormalities, keratopathy, iris atrophy, correctopia, an immobile pupil, corneal clouding, cataract, glaucoma, hypotony, and can cause phthisis of the bulbus. And this is something which you don't want. The risk factors of anterior segment ischemia are advancing age, abnormality affecting blood flow like leukemia, homocystinuria, hemoglobinopathies, small and large vessel abnormalities, diabetes, hypertension, atherosclerosis, carotid artery diseases, and carotid cavernous fistulas. Orbital and ocular abnormalities, for instance, prior uveitis and in thyroid-related orbitopathy. One should never do operations on 3 or more rectus muscles. Especially the superior and inferior rectus muscles are the main feeders of the anterior segment, and if you do the superior and inferior and either the medial or the lateral rectus muscle, you will have a high risk of anterior segment ischemia. And prior surgery, of course, scleral buckle, diathermy, cryotherapy, or other procedures may affect the anterior segment blood flow. So be careful in those already pre-treated eyes. Prevention of anterior segment ischemia, limiting the number of rectus muscles at the same surgery, which I just discussed. Fornix incision can help. The use of botulinum toxin can help in order to do one muscle less. And anterior ciliary vessel sparing. And you see in the photographs on the right side how you can do a recession of the muscle with sparing of the ciliary arteries. Once you have anterior segment ischemia, use cycloplegic agents, topical and systemic steroids. Some cases are described which have a positive result in hyperbaric oxygen and a control of the intraocular pressure. Another minor complication is increased vascularity of the conjunctiva. Increased vascularity of the conjunctiva is common after strabismus surgery, and the eye may not be constantly red, but becomes red with exposure to irritants. For instance, swimming in a swimming pool or in the sea, which either has salt or chlorine. And also other irritants are known, like peeling onions. Here is an example of a slipped muscle. A slipped muscle occurs when the muscle capsule, rather than the muscle itself, is sutured to the sclera. And you see here in this young boy that in the left eye, he has an adduction deficit or limitation after a recession of the medial rectus muscle. So how to prevent it? Place the suture securely into the muscle and then or in the tendon tissue, and suture it at the intended site. How can you treat it? Surgical exploration can identify the muscle, and reattachment of the muscle to the proper scleral location can help this slipped muscle and can be corrected. Here you see an example of a lost slip muscle after a left lateral rectus trauma. This child walked into a beach reek, and the muscle was ruptured from the insertion site. We could retrieve it and put it back on the original anatomical insertion. What we also did is that we used Botox in the left medial rectus, so this lateral rectus muscle could heal without too strong or contracted antagonist the left medial rectus muscle. Lost muscle. A lost muscle is a muscle which has completely released from the sclera, retracting posterior into the pulley sleeve in the orbit. Prevention? Well, place the needle into the sclera and not just episclera. And the treatment is either to retrieve that muscle or do a muscle transpositioning procedure with the help of the half of the neighboring muscles in order to treat this severe complication. Postoperative diplopia. Diplopia is quite common after surgery for concomitant strabismus and usually lasts a few minutes, days, some weeks. And persistent postoperative diplopia is rare and more common in adults, especially when they are overcorrected. Prevention, preoperative correction of the deviation with prism can give a hint of the possible of the postoperative diplopia. In adult patients, avoid overcorrection, and the use of adjustable sutures can help to prevent postoperative diplopia. The treatment can be prisms, occlusion of one eye temporarily, or reoperation. Thank you for listening, and thank you One World, One Vision to give the opportunity to record this lecture. Thank you very much.
Well, Dr. de Faber, that was a wonderfully complete and thorough talk on rectus muscle surgery. I do have just one question for you. You mentioned plications and resections, and I'm wondering if in your experience there's a one-to-one correlation. Is 1 millimeter of resection the same with respect to effect as 1 millimeter of plication? Or do you have to alter your normal table, your surgical formula, if you're switching from resections to plications?
No, Dr. Kushner, I simply use the same amount of millimeters, but I don't go further than 4 millimeters in plications. If I go further, like 5, 6, or 7, then I think simply the bulk of this plication is interfering with a good result. So I do plications, and I do them one-to-one. If I would do a 3 millimeter or 4 millimeter resection, I would do the same amount of plication. And I must say plications are elegant, they go quick, and they're sparing the vasculature if you do it the right way.
Thank you. Very to the point and clear answer. And with that, I'll say this ends the One World, One Vision lecture on rectus muscle surgery. Thank you all.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Burt Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of the lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.